Morning, everybody. I have some conflicts of interest, consultancy and grants. The topics I'm going to discuss this morning are microcirculation, especially concerning use in surgery. I'm going to discuss a little bit about the imaging techniques and how can we use microcirculation to aid hemodynamic management, and how especially to aid surgical management as well. So anesthesia influences organ perfusion. We get a relative hypovolemia due to vasodilation and inhibition of sympathetic nervous system and baroreflex regulatory mechanisms, gives you a decrease in cardiac output and vasodilation. And we act by fluids, iodos, and by vasoconstrictors. But mind you, the surgeon also influences organ perfusion. Based on their surgical technique, open versus laparoscopic surgery, by having patient chemo or radiotherapy, by putting in an anastomosis in an organ like an esophagus, and by inducing blood loss. Also, vascularization of an organ or cutting of vascularization gives damage to arterial vessels, gives venous congestion, and affects the lymphatic system. This also affects microcirculation on an organ level. So what we have learned over the last years is that volume loading is not so easy. Too little fluids is not good, too much fluids is not good. You need to find an optimum. And for every patient, this optimum can be different. But also we know that hypotension is not good for patients and is associated with acute kidney injury, myocardial ischemia, and indeed a mortality increase. So when we look at the microcirculation versus the microcirculation, this is an example of a coronary artery and the microcirculation of the heart. We see that flow pressure and metabolites can be influenced of the microcirculation. And not everything is indeed under our direct control. And more did a nice overview in the BJA, what is influencing the microcirculation, what is regulating the microcirculation. And indeed this is pressure, this is flow, this is metabolic influences, and this is shear stress, for example by hematocrit. So if we want to influence microcirculation, it would be nice to be able to measure it or to visualize it. There are some techniques available at the bedside. Some of them have been discussed by former speakers already, but I'm going to just summarize them a bit. One of them is laser spectral imaging. This is based on the reflection of laser light and the scattering of laser light, which gives contrast in an organ. It's a whole perfusion monitoring. It's really nice to visualize a whole organ this way. You have NIRS that is used also in the operating setting, which is based on the different absorbing characteristics of light by hemoglobin and the oxygenated hemoglobin. Fluorescence imaging is also very nice. You have to use a contrast dye, and this molecule gets in an excited state, and when it's releasing its photon, you can measure it, and you can actually show the whole organ and also the perfusion of organs. Of course, this single point monitoring has been discussed a lot by former speakers. It's the side-stream dark field imaging, which is based on the fact that a red blood cell absorbs the light, so the black are all the red blood cells, and you can really nicely get an overview in detail of the microcirculation. Laser Doppler flowmetry is also used in practice, which is based on the Doppler shift, and you can actually measure the speed of red blood cells. So what is the problem with the imaging techniques? Why are we not using it at the bedside all the time? Well, there are more than one reasons. There are different problems with these techniques, like motion artifacts or pressure artifacts, the time-consuming analysis, which might be resolved, as Professor Inge already said, soon, hopefully, and also the different measures that these imaging techniques have. Some measure perfusion in flux, which is a relative measure, and some have absolute measures. And the problem is, and then we have some challenges to use these monitoring techniques. So how do we interpret signals, relative versus absolute measurements? How do they relate to physiological and pathological processes? The methods itself are difficult to compare, so how do you validate them? And then you have the contact, no contact methods. In surgery, for example, you have a sterilized environment, so probably you would like to use the no contact methods best. And would you like to visualize the sublingual bloodstream, or would you like to visualize the organs itself? It's something to think about, and I think that is still why these methods are not really implemented in the OR setting yet. So how can we use the microcirculation to aid hemodynamics? The former speaker already explained a bit about hemodynamic coherence or non-coherence. Microcirculation, the cellular compartment gets uncoupled in these states, and then it's really difficult to connect macrocirculation with microcirculation. You have some microcirculatory states of shock. You see them more in ICU, but of course you could also see them in the OR setting. In intensive care, microcirculation has been really useful as a prognostic tool. If you have bad microcirculation, your outcome is not so good. There are several articles on this subject, and also the former speaker also showed something. But still, you would like to have a combined monitoring of the macro and microcirculation. A few studies have the microcirculation as clinical endpoint and really treating the microcirculation to improve outcome. We are not there yet. So Professor Inge showed this slide also. This is a theoretical flowchart, how we could combine macro and microcirculation in a shock. This is theoretical in research setting, but I think these are the first steps to do so. So you treat the microcirculation and also measure the microcirculation. And how can we influence the microcirculation, maybe by vasodilators, maybe by red blood cell transfusion, or maybe by anti-inflammatory or cytoprotective strategies. Still theoretical and also not applicable at the OR setting yet, but I wanted to show you maybe where this is going in the future. So what are the problems in the OR setting? We have a totally different dynamics, and we have some limitation that you don't have in the ICU. The effects of surgery, like laparoscopy, the more dynamic use of vasoactive medication, the use of clamping by surgery, and we don't know anything about microcirculation and its association with adverse outcome in these patients. We don't know. We have more literature about ICU, we have some literature on OR setting, and I'm going to discuss some of them, but we don't really know. There's a lack of studies. So this is actually a study shown by the former speaker as well. Hemorrhagic shock, it's an ICU-based study, but I would say it also applies to the OR setting, with many patients who have a form of a hemorrhagic shock. And we know that it adversely affects microcirculation, and that microcirculation can be moving to get independent from each other. We know there's an association between capillary density and outcome by means of the SOFA score, and we know that there is a beneficial response of the microcirculation on blood transfusion if you are early enough. So this is also shown by the study of Tanaka in critical care medicine, and they show that the microvascular flow index and the functional capillary density really improve patients with hemorrhagic shock when you transfuse blood. So this would also be interesting to look into in the OR setting. We use blood, we use blood products a lot, and So you can imagine that microcirculation gets damaged. If you let the condition stay too long, you get edema, and I think that it would be an indicator for adverse outcome. But we're not there, we don't have any literature there, so I would say everybody should look into this subject. So this is a really recent article, also by the group of Ouattour and a former speaker. So they show that preload and fluid loading responsiveness by using the microcirculation is really interesting. So when a patient has diminished preload, you see that by pulse pressure variation increase, by a decrease in cardiac index, and also by a decrease in microvascular flow index by using the microcirculation, and by functional capillary density. They gave a fluid bolus, and what you saw was that the microcirculation improved in line with cardiac output, but not the mean arterial pressure and not the heart rate, which is still what we are following mostly in the OR setting. So this is one of the first studies that actually shows that microcirculatory measurements can be used to look at fluid responsiveness and to treat patients maybe even better and maybe even more patient focused than using cardiac output alone. So I think this is very interesting. Also, another study just showing what surgery can do to a patient is a patient that got a laparoscopic esophagectomy, and they get a pneumoperitoneum, and what you see is that during pneumoperitoneum and steep reverse trend labor, the CVP increased immensely, the mean systemic failure pressure increased. This was associated with an enormous decrease in microvascular flow index. So this was measured by sublingual measurements of the microcirculation. So it's not even on organ level. So it's far from the organs. But you can imagine that what happens under the tongue will also happen in the abdomen due to these pressures that exist. We don't know anything about whether this is bad for the patient because it's temporary, it's for a few hours, it will resolve, but you can imagine that damage gets done to the microcirculation. And actually was really interesting that when you connect macrocirculation to microcirculation, that mean arterial pressure and cardiac output was not really predictive in these patients for a bad microvascular flow index, but CVP and mean systemic failure pressure were, which is more affecting probably on the organ on the organ level. So another thing is, and this is also I think is very interesting, is how can microcirculation measurements aid surgery? There are a lot of description on how microcirculation is measured and how surgeons use it to, for example, use it as a prognostic tool for skin lesions, burns, early graft, postoperative function after liver resection, brain perfusion, histologically damaged livers to make some differences between good and bad parts of the liver, and visualization of vascular gap in esophagectomy. And our group has some experience with the latter, so I'm going to tell you a bit more about this. So this is laser speckle imaging during surgery actually. So this is really great. And in the first picture on the left you see the stomach, which is removed out of the patient. It's still connected of course to the patient, but some of the vasculature was already cut there. And you see the flow at the top is already decreasing. Now on the second, in the middle part, you see the gastric tube has been made. You see already a decrease in flow towards the top where the future anastomosis is going to be. So this is interesting because one of the problems of this type of surgery is anastomotic leakage. So if you can visualize it, maybe you can do something about it. So that was our thought. And then you see that influence of position, and the third picture, the one on the right, the patient gets in anti of reverse Trendelenburg, and you see the blood flow, which is get decreased even more. So to just tell you red is good and blue is bad. And you see also by the white triangle marker, this is we call the watershed. That's actually where there's no real perfusion of vasculature anymore, and the rest is done by diffusion through the tissues. So this is important. This happens with every patient, and this is the cause of all problems after the operation. So if you can visualize it, the surgeons can maybe adapt their techniques and maybe improve vasculature, or maybe locate the anastomosis a bit differently in the body, so patients will have better outcomes. So also what is interesting is to see whether vasopressors can influence in these patients the flow through the anastomosis or the future anastomosis. What you see here, we gave a bit of ephedrine, and on the left you see the before state, and on the right you see the after state. So you do have some influence as anesthesiologists, which is interesting to know because that is always the case. The question is whether these influences can be also be done after the surgery. You don't have that easy tool to visualize what is happening right there. And how can we influence the vasculature or the microcirculation after the surgery closes the wound and after the patient goes to the ward. But still, these are small steps for beginning for a solution of a big problem, hopefully. Really recently, there was there's some review article, systematic review for a group of patients with a historically controlled subset, where surgeons used contrast imaging, fluorescence in this case, to visualize the vasculature around the anastomosis, and also they could make changes in the surgical plan after they visualized it, and their patient did so much better than those patients where those tools were not used. So although this is a review with combined patients groups and historical control group, this is really a marker for the future that we can do something about it. And we need more prospective studies to see how we can do this. So to conclude, tools visualizing the microcirculation whole organs are useful, but should be simplified, non-invasive and less time consuming to be used at the bedside. More studies need to show benefit for monitoring, for hemodynamic control. I think there's a high potential for intraoperative surgical guidance and prognostics by using microcirculation. Unfortunately, few correlations with outcome are studied, and I think this is a message to us to work on that subject particularly. Thank you for your attention.